It's my pleasure to invite Dr. Mudit Tyagi for the next talk on common posterior segment inflammatory conditions. Dr. Mudit is a senior consultant at the LV Prasad Eye Institute, Hyderabad.
All right, thank you so much, Abhilasha, Dr. Mallika Goyal, and the entire team at AIOS and the scientific committee for having this instruction course. And what I will be talking about is basically common posterior segment conditions, inflammatory, infective or non-infective, which can be identified easily by all ophthalmologists and which can be initiated as far as the treatment is concerned. And the most important point, first of all, is to identify these conditions. So I'll be focusing on how we can identify some of these common patterns clinically. So the first thing whenever we see any ocular inflammatory condition is to first of all determine whether are we dealing with an infective or a non-infective cause, because obviously the treatment will be different. While it's just non-infective, then our main armamentarium of treating these diseases is essentially steroids. But if it is infective, then the most important step is to initiate an appropriate antimicrobial treatment. And therefore, the first step has to be identifying and differentiating between an infective versus a non-infective underlying etiology. Now, moving on to some of the common infective organisms and common infective retinal inflammations that we can see in our clinics. The first thing, like I said, and this is something which I keep on telling in all talks on pattern recognition, are first of all differentiate between the level of involvement. Are you dealing with a retinal involvement or are you dealing with a choroidal involvement, meaning thereby choroiditis? Now it's easy to identify clinically. If you see a lesion which is superficial and which is obscuring an underlying blood vessel, then it becomes easy for us to understand that this is a retinitis lesion. Whereas if a lesion is deeper, then you will see it deeper, number one, and number two, you will be able to see a blood vessel coursing over those lesions. So if you see blood vessels coursing over lesion, it becomes self-explanatory. It's intuitive to understand that this is a choroidal lesion which is pushing things up, and you can see an overlying blood vessel over this. So deeper lesions with blood vessels coursing over them, choroidal. Superficial lesions which are obscuring the blood vessel, retinal involvement predominantly. So the other point to remember is all retinitis is infectious unless proven otherwise. So whenever you see a retinitis lesion, you start with the premise that there is an underlying infection and you need to identify and rule out infections before going on to anything else. So the most common unifocal retinitis that we will encounter in our clinics is ocular toxoplasmosis, and this again is a disease which can be easily identified. So if you see a unifocal retinochoroiditis lesion, you can see these chirally plaques and this occlusive vasculitis. Think of ocular toxoplasma. So it's the most common cause of infectious retinitis in our clinics, most common cause of unifocal necrotizing retinitis, also one of the most common causes of membranous vitritis, and a lot of times you will see a dense significant vitritis, so what used to be classically described as headlight in fog sort of an appearance. So if you see a dense vitritis, but beneath that vitritis you are able to appreciate a single retinitis lesion, then that is toxoplasma. If you see a dense vitritis but you see peripheral lesions which may be confluent, then think of acute retinal necrosis. These are the two most common causes of dense vitritis. Also remember, if you see a lesion adjacent to a scar, so a retinitis lesion adjacent to a pigmentary scar in most cases will end up being an ocular toxoplasma. So unifocal retinitis lesion like what we just discussed right now, they do not have any consistent direction of spread and can be having a neurosensory detachment when you do an OCT. You can have arterial plaques and sheathing. Remember the pattern of recurrence. So most of these lesions recur from the edge of an old scar. So you see a scar, you see a retinitis lesion adjacent to it, your diagnosis becomes fairly simple. You are dealing with ocular toxoplasmosis. Compared to that, if you see a recurrence from the center of a scar, so you see a scar and you see a recurrence in the center, then it probably is tuberculosis. So these are two patterns. Tuberculosis lesions recur from the center of a scar. Toxoplasma lesions have a recurrence from the edge of the scar. And if you identify them, you will be able to pinpoint etiology of the disease in most cases. So let me just show you this one case. This was a patient who was initially treated as a viral acute retinal necrosis, was given intravitreal ganciclovir also once, was also treated with oral valacyclovir. But when the patient came to our clinic, what we saw was this area of retinitis in the periphery. But the important clincher was that there was a scar adjacent to it. And just now we said that a lesion adjacent to the scar is probably a toxoplasma. We started this patient with Bactrim DS and see how the lesion starts regressing. Now that is another point which we need to, as ophthalmologists, learn to identify the signs of resolution. So when the lesion starts becoming regressing, the margins start becoming more well defined, the vitritis is decreasing, those are the signs of clinical resolution. So while if you look over here in the earlier photograph, you can see these obscure, hazy, diffuse margins. As the lesion starts regressing, the margins start becoming more and more well defined. So this is how the patient responded after starting the patient on Bactrim DS, and this is how the patient was subsequently. So identify the pattern: retinitis lesions adjacent to scar, toxoplasma. Serpiginous-like choroiditis, again another pattern which can be easily identified. You can see these lesions over here which may not involve the peripapillary area. You can sometimes see unifocal lesions. Usually unilateral, can also occasionally be bilateral with this pigment clumping. Again a clue to underlying serpiginous-like choroiditis, and you know the etiology over here in most cases is ocular tuberculosis. CMV retinitis, again a disease which can be clinically identified. So you can see these retinitis lesions with central hemorrhages. Think of CMV retinitis. Also, while we presume that these happen only in seropositive patients, it's also important to remember that they essentially happen in patients who are immunosuppressed. So if your patient is taking long-term immunosuppression for any reason, if the patient is post-transplant or on immunosuppression and you see these lesions, your diagnosis becomes fairly simple. You are dealing with a case of CMV retinitis. What is another point which we need to remember is that these eyes will not have a very significant AC inflammation, and the reason is that your patients are so immunosuppressed that they are not able to mount an adequate immune response. So when you see retinitis lesions with an absence of associated AC inflammation, that's a clue to the fact that you have got an immunosuppressed or immunocompromised patient, and those patients then need to be investigated accordingly. Check for their immune status, check for the CD4 counts, check for HIV status, and you will know that you are dealing with a case of CMV retinitis. It has its own characteristic patterns, like I said. So extensive retinitis with these hemorrhages, a frosted branch meningitis, all of those are clinical clues which can be easily identified just on a good indirect ophthalmoscopy as a case of a CMV retinitis. Another common disease, acute retinal necrosis, again predominantly a clinical diagnosis, can happen in immunocompetent as well as immunocompromised host. You may have a moderate AC reaction, but you can also have a significant vitritis. These lesions are predominantly spread in the periphery, and then you can see these coalescing confluent retinitis lesions. Frosted branch meningitis, another pattern which can be identified, and what we need to remember is that frosted branch meningitis can happen in these few cases. It can be idiopathic, can happen in HIV positive patients. It can also be a clue to sarcoidosis, lymphomas, leukemias, and SLE, and therefore it becomes important for us to identify these patients. You see a frosted branch meningitis, if you are not able to find a etiology, it's always good to get a complete blood picture as well as a peripheral smear done. We have had 2 cases where lymphoma is presented with this sort of a lesion over here. Another common clinical pattern which we often discuss in uveitis circles is ocular syphilis. Now this is a disease which earlier we thought had gone away from our clinics but has now come back with a vengeance, and these are very classic patterns. So if you see a placoid chorioretinitis with infiltration more at the edges of the lesion, if you see this ground glass retinitis with a central clearing, or if you see these multiple medially lesions, these can be a clue to underlying ocular syphilis. It's not necessary that if you see these medial lesions that's 100% syphilis, but the moment you see these lesions, it should set your bells ringing and you should entertain the possibility of a differential diagnosis of ocular syphilis being one of the causes. I'll just take 1 more minute for this. So if you do an OCT through this placoid retinitis, you will see this RP nodularity, and an OCT through these miliary lesions may show a full thickness retinitis. If that's there, it kind of clinches it to be possibly a case of ocular syphilis. So these are common patterns which we can easily identify. These are some of the common. Why has this got stuck? And there, I think there are some overlap of the slides over here. Can you please just check my presentation? But in the meanwhile, while they're checking it, I will anyways will be ending this talk. So these are some of the common patterns which we can very easily identify just based on a good clinical evaluation, and that is something which as ophthalmologists all of us need to do. All we need for these diseases is a good indirect ophthalmology and a good clinical evaluation. Thank you so much.
Mudit, one question, very good talk. Would you have a certain guideline for management of retinitis versus management of choroiditis? A broad outline for a comprehensive ophthalmologist?
All right, so broad outline like is the first step is number one to identify whether you are dealing with infective or non-infective. Once you are there, for all of our patients, essentially we do get a few tests done for every single patient. You do not have to get every single test done which is available, but few tests are absolutely essential. Number one is serology for HIV. The reason is not because you are suspecting HIV in all diseases, but also the fact is that you will be treating these patients with long-term steroids even if they are non-infective. So if they are non-infective, you may be treating them with steroids or subsequent immunosuppressive agents. Therefore, it's important to get a serology done for HIV also, not because of the underlying disease, but otherwise. It's also important to get testing done for syphilis for every single case. Syphilis is such a big masquerade that it can present with any form of lesion. It can present with AC inflammation, anterior uveitis, keratitis, choroidal lesions, choroidal granulomas, retinitis, ground glass retinitis. All patterns of uveitis can be a manifestation of ocular syphilis, and therefore it becomes important for us to get a testing done for syphilis for every single of these cases. Once you have done that, now you know that you are dealing with other diseases, and then you can tailor your investigations accordingly. So if you are thinking of choroiditis, usually we do get them investigated for tuberculosis, number one. The second cause of choroiditis also happens to be sarcoidosis. So we do get a contrast enhanced CT done for most of our cases if our patients can afford it. Remember, not a chest X-ray or an HRCT, but a contrast enhanced CT is the investigation of choice in these cases. That can in often a lot of cases help us in deciding whether we are dealing with a sarcoidosis also. And then you can start your treatment accordingly.
Good, thank you.
Dr. Mudit, what is the test for syphilis now that syphilis is making a resurgence? Which is the one test for syphilis that you advise?
So the two tests which are commonly available, which most people get done, are the non-treponemal and the treponemal test. Both of them are very easily available in most of the labs. So the non-treponemal one is VDRL, the treponemal one is TPHA. The test to be done ideally should be a treponemal one called TPHA. The reason is that TPHA has got a very high sensitivity and specificity for syphilis. So if you've got a TPHA positive, and TPHA is a 94 to 95% sensitivity and specificity for syphilis. So get a TPHA done. Also a VDRL. VDRL is useful to monitor the response to treatment. So a clinical resolution of lesions along with a 4-fold reduction in titers is the definition of clinical cure for syphilis. But to identify the disease, if you have to ask me what is a single test you will do, that should be a TPHA. That should be done for all of your patients.
Thank you.
Thank you so much.